So now we'll talk about aneurysms, especially from a surgical perspective. We'll start off by discussing the contents of this discussion. We'll talk about, first of all, the types of aneurysms, how we can classify aneurysms. Secondly, we'll go into the details of abdominal aortic aneurysms. Then we'll move on to the peripheral aneurysms. And finally, we'll talk about thoracic aneurysms. So we can start off by talking about aneurysms and how we classify them into different types. The first thing that we have to notice in an aneurysm is whether it is a fusiform aneurysm or a saccular aneurysm. What that means is we are referring to its morphology, which is if it's fusiform means that all the sides of the vessel are involved. If it's saccular, then it's a sac-like protrusion which is causing that aneurysms. Another way to look at an aneurysm is by the content of its walls. In this one, you can notice that only one wall, which is usually the outermost, has bulged out, and this kind of an aneurysm, we call it a false aneurysm. And on the other hand, this one is called a true aneurysm because all three layers of its wall have bulged outside. And lastly, we also talk about aneurysms with regards to its etiology. So we can have mycotic, but remember, mycotic may sound to you as if you're talking about a fungal cause, but mycotic in this case is a misnomer and actually means bacterial causes of the aneurysm. On the other hand, it can be atheromatous, which means that it is due to atherosclerosis. It can be due to collagen disorders like Marfan syndromes or Ehlers-Danlos syndrome, or it can be due to trauma. And make sure that you understand that when trauma is involved, it usually results in a false aneurysm, which we mentioned before as being this one. Right, and which is the most common type of aneurysm? If we put all of these together, it is the true fusiform atherosclerotic aneurysm. Right, so we'll move on to the next point, which is the abdominal aneurysms. And now we'll go into the detail of specifically abdominal aneurysms. In this diagram, what you can see is the anatomy of the abdominal aneurysm. It most commonly occurs right before the bifurcation of the abdominal aorta into the common iliacs. So now, first of all, you have to understand that it is most common, and we can talk about how do we manage the asymptomatic abdominal aneurysm versus the symptomatic aneurysm. So the asymptomatic aneurysm has to be managed by, first of all, screening. The screening tool that we use most commonly for this is the ultrasound. Right? It is non-invasive and it can give you a good idea. With regards to its treatment, we have to consider the diameter of the aneurysm before we can decide whether we want to repair it immediately or we want to delay it. If the diameter of the aneurysm is more than 55 millimeters, then we might have to go for elective repair of that aneurysm, even though it is asymptomatic, but we have a risk of rupture, so then we would prefer to go for elective surgery. If it's less than 55 millimeters, then we can do usually regular follow-ups. So what you do is you bring the patient for follow-ups and you keep doing the ultrasound and check if the situation is getting worse or whether it becomes symptomatic, for example. On the other hand, if the aneurysm starts becoming symptomatic, when it's symptomatic, what we usually mean by symptomatic is you start getting symptoms of abdominal pain, right? And these are not so severe as it would be if it ruptured, but the symptoms of pain usually indicate that we are moving rapidly towards a rupture. So even in this case, if the patient is fit, then you would like to go for operation as soon as possible, right? We are not going to delay it and do any follow-ups for this patient ASAP, right? What if the aneurysm has actually ruptured? Now we'll talk about the situation of a ruptured abdominal aneurysm. So now, first of all, we need to talk about what is the most common location of the rupture when we refer to the abdominal aneurysm. Does it most commonly rupture anteriorly or does it most commonly rupture posteriorly? The answer is it most commonly ruptures posterolaterally, right? So because the aorta is mostly a retroperitoneal structure, which means it is behind the peritoneum, if it ruptures posteriorly, the blood usually flows back into the retroperitoneal space, and it can usually cause accumulation behind the aorta. On the other hand, if it ruptures anteriorly the blood goes and it settles down as free peritoneal collection. It does not cause a hematoma as it would cause in the back, because retroperitoneal space is a constricted space, while on the other hand, the anterior peritoneal space is an open space where the fluid can accumulate. Right. Another important thing that we need to remember is the triad of ruptured abdominal aneurysm. Number one, abdominal pain, right? Hypotension, decreased BP, and a pulsatile abdominal mass. All three indicate to you that we probably have an abdominal aneurysm rupture. Also, when a patient presents with this triad, you could do an ultrasound immediately, which might help you understand that it is an aneurysm, but the preferred one, the diagnostic one for a ruptured aneurysm, is a CT scan. It is fast and it will tell you exactly what the problem is. And lastly, what is the choice of treatment for your ruptured abdominal aneurysm? You have to start off by infusing fluid to the patient, but we have to make sure that we don't over infuse fluid, because if you give if you give the patient too much fluid, what you will end up causing is the hemorrhage will actually become severe, because the more fluid you will put into his system, the more pressure there will be in the blood vessels, and as a result, more hemorrhage will occur. So you try to give him fluids just enough for cerebral perfusion to happen. So you have to keep it under 100 millimeter mercury. That's your target for the fluid infusion. And if the patient is stable, that means if he's hemodynamically stable, he's awake, he's conscious, his blood pressure is all right at the moment, you can delay the surgery till you get blood, right? So you have sent the blood of the patient for cross-matching, and to make sure you get 6 units of blood before you start the surgery, only if he's stable. If he's unstable hemodynamically, you immediately transfer the patient for surgery. Right, so now we need to talk about the abdominal aneurysm investigations. So there are some usual investigations that you do in just about any surgical cases, and on the other hand, we have some specific investigation which is done to assess the morphology of the aneurysm. So the usuals which you have to do, make sure you do the full blood count, you do the liver function tests, you do the coagulation profile, you do the lipids, and you do make sure that you do cross-matching. This is very important because you have to get approximately 6 units of blood before you actually take the patient for surgery, if you have the time, that is. And ideally it is done days before the surgery. So we have to do ECG and chest x-ray. These are also some things to be done. On the other hand, to assess the morphology of the aneurysm itself, the preferred one is a CT scan. Next, we'll move on to the choice of surgery. So you can either have an open surgery, or you can either do an endovascular aneurysmal repair. Right, so open surgery can be done, but obviously endovascular aneurysmal repair is preferred if you want reduced mortality, but you might not get time for that during an emergency situation, so you have to weigh your options. Here you can see a stent is being placed just on the inside of the aneurysm. That is what we mean by endovascular aneurysmal repair, and here is a stent, you can see that, right? So next we'll move on to the post-operative complications, right? So you have complications if you perform the open surgery, and you have complications if you perform the endovascular aneurysmal repair. If you perform the open surgery, there is a risk of cardiac ischemia, obviously, because if the patient is losing a lot of blood, there will be decreased cardiac perfusion, and that might be one of the causes of cardiac ischemia. You have respiratory complications like atelectasis, which is the collapse of the lungs. You can even have lower lobe consolidations. On the other hand, you can have colonic ischemia, again the same reason. You're losing blood really fast, so some of the intestines are not perfused enough, which can even result in colonic ischemia. Renal failure can happen, especially if the patient has previous renal impairment preoperatively, or if the patient is again undergoing considerable blood loss during the operation itself, which can result in decreased perfusion of the kidneys and result in renal failure. And there is a special one, aortoduodenal fistula. So the reason this happens is because we have the aorta here, for example, and we have the intestines right behind the aorta. So what happens is, if a fistula forms between the aorta and the duodenum, high pressure blood starts flowing from the aorta into the duodenum, resulting in fresh blood present in the intestines. So what that results in, it can happen two things can happen. It can either go up or it can either go down. If it goes up, it can result in blood in your vomit. We call that hematemesis. If it goes down, it results in fresh blood in your stool, or even old blood in your stool, which we call something called melena. So melena can happen, or on the other hand, hematemesis, right? And as for the complications of endovascular repair, you can either get a leak of the stent, you can get the migration of the stent, which means that the stent itself moved from the place that you placed it in. You can have occlusion of the stent itself, it could get thrombosed. And the idea is, in endovascular aneurysmal repair, we have to make sure that we follow up the patient using duplex scanning or CT scanning. Right, so the next thing we're going to move on to is the peripheral aneurysm. Up till now, we have been talking about the central abdominal aneurysm, but now we're going to move on to the peripheral circulation, peripheral arteries, and there are three of them which we're going to discuss. We're going to discuss the femoral ones, we're going to discuss the iliac ones, and we're going to discuss the popliteal ones. So the femoral one, you can see this is the aorta, this is the common iliac, and here we have the continuation of that, which goes down to the legs. At the level of the legs, we have the femoral aneurysm. On the other hand, in the iliac one, you can see that after the bifurcation is the common iliac, so here you can see an aneurysm. And in the popliteal, this is a very beautifully drawn leg, and the knee I made sure to label so it's easier to identify that it's a leg. And just at the joint behind, on the posterior side, you can see there is an aneurysm. This is called the popliteal aneurysm. So we'll start off by talking about iliac aneurysms. First of all, it is common with associated aortic dilation. So you can see that other than the iliac aneurysm, over here we have an aortic dilatation as well. And for iliac aneurysms, we usually prefer open surgery because most of them present with rupture. So you can see that most of them present with rupture. Next, we'll talk about the femoral aneurysm. First of all, it is most commonly is false. False, if you remember from what I previously mentioned, is that false usually involves the outer layer of the artery and not the inner two layers, which are the intima and media. So if you remember, another thing, what I mentioned to you before about the false aneurysm is that usually when trauma is involved, it results in a false aneurysm. So what could be a trauma to the femoral artery? It is past surgery. So imagine if the patient had past non-invasive procedures or invasive procedures. So imagine if in the past the patient had surgery which involved femoral artery. In that scenario, you will have outbulging of the outer layers of the femoral artery, which will result in a false aneurysm presenting later on in life, and this can result in a femoral aneurysm. So in a femoral aneurysm, and especially a false aneurysm, what the treatment which is preferred is thrombin injection using ultrasound guidance. That is the preferred treatment for femoral aneurysms. And finally, you move on to the popliteal aneurysms. You can see that in the diagram, the location is just at the level of the knee, and most commonly it presents bilateral in both the legs at the same time. And the diagnostic investigation that you have to do is duplex, and the therapy depends on two things: whether the patient is asymptomatic or he presents with an acute presentation of the popliteal aneurysm. So if the patient is asymptomatic, you can choose to perform an elective surgery for the patient, and especially if it's more than 25 mm in diameter. And if the aneurysm presents with an acute presentation, they usually present with a thrombosed and ischemic foot. That is normally the acute presentation of the popliteal aneurysm. Then in that case, usually surgery is not indicated, because usually when you present with a popliteal thrombosed aneurysm, the distal vessels are thrombosed already. And therapy that we prefer is something called a Fogarty catheter, used with intra-arterial thrombolysis. So what is a Fogarty catheter? Fogarty catheter is basically a catheter with a balloon at the end of it, and this is specially made to reopen vessels which have been thrombosed. So if the thrombosis is present in the vessel, let's say this is the vessel and here's the thrombosis present at the site of the aneurysm, you basically, because the patient presented with the presentation of thrombosis and ischemia, your goal is to reopen that vessel and make sure you reopen that thrombosed vessel. So what you do is, this is the Fogarty catheter, you put it distally to the thrombosis and you start pulling it back, and you dilate it when it comes here, so that this area in the middle reopens and your vessel looks like this at the end once the Fogarty catheter has passed. So this is what it looks like. So now your blood has enough lumen to pass through, and it can, reopen your vessels. Right. So the last part that we have to talk about is the thoracic aneurysms. And for thoracic aneurysms, there are two types. There is an ascending aneurysm and there is a descending aneurysm. We call it ascending aneurysm because the blood first ascends, then it descends in the thorax. So these are the two types of thoracic aneurysms, and we now talk about the causes of them. The most common cause is atherosclerotic. Right, so if atherosclerosis is the most common cause of thoracic aneurysms, there are other causes like the collagen disorders that I mentioned before, Marfan syndrome, Ehlers-Danlos, or trauma, which causes what type of aneurysms? False. Correct. So what are the clinical features? What's special about thoracic aneurysms is their clinical features. And the clinical features are mostly space occupying. So if an aneurysm is present in your thorax is a confined space, and there are other structures other than your aneurysm, other than your aorta inside your thorax. And most of the clinical symptoms that you get is because of your aneurysm pressing on those other structures. In this diagram, I have shown some of the structures which we will directly correlate with the possible symptoms that we will have in thoracic aneurysms. So let's start one by one. The blue structure that you see is actually the bronchus. So you see the right main bronchus and you see the left main bronchus. It is mostly the left. Oh, by the way, don't consider this diagram as being anatomically correct, because it is just meant to show to you what are the other structures present in the thorax, which the aneurysm can compress on. It is not anatomically correct, right? So coming back, the blue is the bronchi. We have the right and we have the left. It is the left which is the one on which the aneurysm can compress, and so you can end up with dyspnea or breathlessness, right? The next thing is the orange structure here, which is the esophagus. So if your aneurysm presses on the esophagus, you can end up with dysphagia. You won't be able to swallow properly, right? The next thing you have to look at is the yellow nerve. You want to guess which nerve it is? It is a recurrent laryngeal nerve. You might be wondering, what is a nerve which is supposed to innervate our laryngeal muscles? What is a nerve like that doing at the level of the aorta? Well, it's because that is the normal trajectory of the recurrent laryngeal nerve on the left side. On the right side, it just comes down and goes up under the subclavian artery, while on the left side, it comes down and arches right under the aorta. So this is the normal pathway of the recurrent laryngeal nerve, and if your aneurysm enlarges enough to compress on this, it can result in hoarseness of voice. So which is quite anatomically far from the your throat, your larynx is quite above, while your aneurysm is quite below. So you might feel that it is something unrelated, but that is another complication which can be caused by the aneurysm in the thorax. Another structure which you have to look for is the vertebra. These white structures in the center are the vertebral column, and if the aneurysm starts pressing on this, it can result in pain in your vertebra. Right. Also, there's another complication which is directly related to the heart. This right here is the pericardial space. If the aneurysm ruptures, what can happen is that blood can flow down into the pericardial sac, and it can result in cardiac tamponade. Another cardiac complication which can happen is, as you can see, it is at the aortic root that this aneurysm is present, and what else is there at the aortic root is the valve, which is the aortic valve. So if the aortic aneurysm enlarges, let's imagine this is the vessel, this is the aortic root, and this is the valve. If you have an aneurysm at this point, what will happen is those leaflets of the aortic valve have been separated now. So what that can result in is aortic regurgitation, and the blood will flow back into the heart. That is an important complication that you have to keep in mind for thoracic aneurysms, regurgitation. So now we'll move on to the diagnosis of thoracic aneurysms. CT and MRI are the most accurate. They will show you the most detailed morphology of the aneurysms. And as for the surgical indications, if it's ascending aneurysm, then if there is regurgitation, if it's 5 to 6 centimeter wide, or if it's symptomatic, the symptoms I have already mentioned to you in the previous slide, all these are indications for surgery of an ascending aneurysm. For a descending aneurysm, if the descending aneurysm is rapidly enlarging, if it's 6 centimeter wide, if it's symptomatic. These are the surgical indications for each of them. Right, so now we'll talk about the surgery for thoracic aneurysms. For an ascending aneurysm, this is the ascending and this is the descending. For an ascending aneurysm, the basic concept is to replace the problematic portion of the aneurysm with the replaceable prosthetic part. So this is an operation which is also called the Bentall's operation, which replaces the valve, root, and aorta at the same time by just replacing the aneurysmal portion. On the other hand, if the descending is involved, we have options of putting a stent inside, similar to what we did for the abdominal aneurysms. So just keep the Bentall's operation in mind. It replaces the valve, the root, and the aorta itself, because the ascending portion does have normally the aortic valve inside of it. So the repair that you actually put in must also contain an artificial valve as well. And there is actually a risk for treatment of the descending aorta, which is paraplegia, which makes sense because during the operation itself there will be decreased blood supply to the spinal cord arteries as well, and this could result in paraplegia of the patient. So that's about it for the lecture. If you found it useful, go ahead and leave a thumbs up, subscribe to the channel for future content, and if you have any topic in mind which you would like me to cover, make sure you leave it in the comment section below, and good luck.